convince you the value of tests on various kinds of challenging malocclusion treatments. I'd like to extend my special thanks to the organizing committee for their kind invitation and all the kind arrangement. The topic I'm going to share today is non-surgical treatment of the challenging borderline cases. And here is slido.com. You can scan the QR code to join the Q&A. If you have any question for me, please type it down and I will be answered on this slido.com. And if you are interested in any paper I mentioned on my papers, you may leave your email. Leave your email address on that, and I will send them to you very soon. Okay, here is the slido.com. You may scan the QR code and join the Slido. Okay, I'd like to start my presentation with my gratitude to Dr. Zhang Lin and Dr. Hee-Mun Kyo, because in 2000, Dr. Zhang Lin invited Dr. Hee-Mun Kyo to deliver the first test lecture in Taiwan. And this is the start. I explored the use of tests. So after that, Taiwan was lucky enough to host the third and sixth AIOC, Asian Implant Orthodontic Conference, and also the second WIOC in 2010. So the use of tests in Taiwan is more and more popular. Initially, I just used the tests for regular protrusion cases. Like this lady, a very common protrusion in our daily practice. Nothing else, just bimaxillary protrusion, but not very severe, just moderate. So after 4-bite extraction and the interradicular mean screw, as Dr. Kyo taught us, we use the interradicular interdental mean screw as an absolute anchorage to retract, close all the spaces. So it is quite easy for us to achieve absolute anchorage without anchorage loss to achieve a good profile improvement. Here we can see the sphenometric superposition. Almost no effort to achieve this kind of maximal anchorage to obtain a good profile change. But since this case was just moderate protrusion, but there must be some challenging cases. You will see the requirement at anchorage may not be just maximal retraction. We may need more than absolute anchorage. We may need to distalize the whole arch even after complete space closure. Otherwise, the profile improvement may not be good enough. For this lady, we can see, in addition to 4 bicuspid extraction, because of the hopeless lower left second molar and the endodontic involvement in the lower right first molar. So we decided to extract 4 premolar. Besides, we add lower 2 molar extraction plus upper terminal, wisdom teeth removal. But after extraction, sometimes you will feel regret. You can see so much spaces in the lower arch. Everyone can imagine. If you close all the spaces in the lower arch, you will get a large object, unless you can retract the upper arch. even though all the extraction spaces has been retracted. Luckily, with the ICC test, you may notice here the position is not interdental because we try to distalize the whole arch after complete space closure. So with the ICC test, we can keep the overjet pretty good before and after. After we close all the lower spaces, we can keep pretty good overjet. And the profile, we can improve pretty much. So that is a new concept to me. Not only absolute anchorage, because when we make a superposition, we can see molar distalization. Not only maximal anchorage, but also total arch distalization after complete space closure in the upper arch. That's why we can achieve this kind of non-surgical treatment for this kind of borderline cases. In the past, I think she must be a surgical case. But the key to success might be the ICC test, which is outside the dental roots. You can imagine if the test was placed in between the dental roots, you can achieve maximal retraction. However, if you put the minuscule outside the dental roots, even the space was closed, it is possible to retract the whole dentition to achieve a better profile improvement. So after this experience, I tried to use tests in various kinds of challenging cases when patient did not want to receive orthodontic surgery. Here are some challenging cases I like to go into discussion, like protrusion, gummy smile, vertical maxillary excess, open bite, asymmetry, and class 3. There are many cases which require orthodontic surgery. However, there are many patients, they hesitate to receive the orthodontic surgery. So please be sure that I'm not trying to do periodontics. It's just because the patient, they do not want to go for surgery. And the doctor might be as good as his patient. You may see the profile changes for these patients seems okay, which may be beyond my expectation before I started the treatment. Here we have a severe protrusion case with a severe gummy smile. And here we can note the upper incisor, the torque, was pretty upright, which means the retraction would be very difficult because the anterior teeth tend to dump when we retract it pretty much. So after full bite extraction and wisdom teeth removal, we need to take care of the torque. Otherwise, it starts with very upright position, then it will lingual tilt. So I need to procline the upper incisors, establish the torque for the upper incisor first with the rectangular archwire. And secondly, we need the anterior test to open the deep bite before we try to retract. Otherwise, the upper incisor may impede with the lower incisors. It would be impossible for upper incisor to retract. So with the anterior test, you may see the bite can be opened predictably. If there is an intrusive force, of course, we can intrude the incisors. If we intrude the incisors and the overbite can be opened smoothly, then we can use the IZC test for maximal retraction to reduce the protrusion. However, we need to control the torque during the space closure. In this case, I use the Warren torquing spring to control the upper incisor torque during retraction. With this force system, we may close all the spaces. Then here we can see how the facial profile was improved and the gummy smile was gone. However, here we can see the exoastosis after massive amount of retraction. Here is before and after. After massive amount of incisor retraction, we can see a lot of exoastosis like this. So we sent this patient to the periodontist to receive the crown lengthening and removing the exoastosis and restore the appropriate crown length. If we look at the superposition, it's around 8 millimeter incisor retraction, but also we may notice a little bit upper molar intrusion, which allow the mandible to rotate counterclockwise, just like Dr. Artis just showed. I call this a kind of active vertical control because we intrude the upper arch, including the upper anterior and upper posterior, so that the occlusal plane was moved upward so that we can rotate the mandible counterclockwise to improve the chin projection and also improve the facial profile. If we look at the mandibular plane angle, it was reduced and the gummy smile was successfully corrected with this combined intrusion and retraction force system. Let's say for an orthodontist like you, everyone know if we have an absolute anchorage in the posterior and also have an absolute anchorage in the anterior, then everything should be very easy for you to control, right? Because you have these anchored. You can control the vertical, you can control the sagittal. So I'd like to proceed to the next, which is not so severe, just a regular protrusion. And again, 4Y extraction, then a little bit deep bite, but I use the anterior test to open the deep bite. Then use the upper posterior test, IZC test, for maximal retraction. So with this force system, we can correct the protrusion case very easily, very predictably. 1.5 years, we can correct the occlusion. It looks all good, but I'd like to show you something. The facial profile improved quite a bit, but when I make a superposition, please note that the upper incisor torque was not controlled very well. I think if we can torque it a little bit appropriately, there might be a better response for her facial profile improvement. Oh, sorry. So we start to use the 17 by 25 TMA with the palatal root torque around 30 degrees. Then we hold the dentition with the IZC test so that it will not make the crown flare out. And here is the end of treatment. Occlusion-wise, it looks about the same. However, if you look at the chin projection, it looks a little bit better than the mid-treatment. If you look at this comparison, pre-treatment, mid-treatment, after complete space closure, and after torquing the upper incisors, you may see further facial profile improvement with the chin projection improved. Here is the OPG before and after, and here is the supermetric superposition. It looks the retraction of the upper incisors, bodily retraction, which allow the mandible rotate further. Because if we look at the mid-treatment cephalogram, the upper incisor was dumped a little bit, retract more. However, when you retract more, the chin does not come forward. If I can regain the torque, then the response of the chin projection would be a little bit better, which will further improve your facial profile. So again, the comparison, pre-treatment, mid-treatment, and post-treatment. These are the numbers. Upper incisor to SN, regain the torque, then we can improve the facial profile, like this, and also the chin projection. So, although many cases look about the same, however, there is a little bit difference if you can look into some details. So, it's about 30 to 40 degrees palatal torque on the TMA archward to give the palatal torque. Of course, I believe many of you are quite familiar with the palatal torque, wire bending. Nothing too much to you. And the final should be like this, so you can read the torque on the archward. Like this, around 30 to 40 degrees. Okay, but of course, you need to adjust the posterior part back to zero, right? Back to zero. Besides that, I also want to let you know another thing is about the, in addition to palatal torque, because we retract pretty much, the upper molars tend to rotate buccally. The palatal cusp hanging down. And there is one adjustment I will do is buccal torque on the terminal molar. The buccal torque on the terminal molar. And also towing back if necessary. If the terminal molar was rolling out. So the archward bending looks like this. 30 degrees buccal torque and 30-degree towing back. Okay, so that is thanks to Dr. Adi's presentation. I believe many of you knows very well about the concept of the active vertical control. But you know, in the past, I dare not accept this kind of patient for non-surgical treatment because I think she is so severe. I do not know where to go. I do not know what's the objectives of orthodontic treatment. But with these concepts, I can show the patient that we can do this for you, but we cannot guarantee the final outcome because I think you should be a surgical case. So, whole body extraction, combined intrusion and retraction. But this time, because she is so severe a case, I applied the same force system from top to the bottom. So combine intrusion and retraction force system on both arches. And we can close all the spaces. However, you may see after we close all the spaces, the facial profile may not be so good. Better, much better. Patient was satisfied, but we do not know if it is the end. I do not know because we are trying total arch visualization on both arches. So here is the final outcome we achieved. This is the final outcome. But the patient was happy. The patient was happy. But actually, we need to know that some patient will ask you, what will I look like after debonding? Sometimes I do not know, because it depends on your anatomy. It's your condition. We can do everything we can help, but I cannot guarantee how much we can improve. But for this kind of severe protrusion case, with this, the combined sagittal and the vertical improvement balance her facial profile much more. And here is the symmetric superposition. I mean the measurements. We can see the reduction of the facial profile and also the vertical height. The medial plane angle was reduced pretty much. But here is the before and the after. And mid-treatment, yeah, of course. At this stage, you may say, yeah, it's the end. But actually, we can continue the force system to see if there is anything we can help. Trying to wait and further retraction to see how it is possible to maximize the profile improvements. And here we can see the combined vertical and sagittal correction with the combined intrusion and retraction force system on both arches. But you know, we are just trying. We are trying to help, but we cannot say how much we can improve. For this kind of vertical measuring excess, it's even more challenging because there is no way we can reduce your vertical height without surgery. So for this kind of severe gummy spine, of course we will suggest orthodontic surgery. But of course, the differential diagnosis decision tree, I'm not going to go deep in this, but I can mention this for skeletal and dental gingival factors. It is possible for us to use the combined intrusion and retraction force system to correct the gummy spine. Because in the past, it is definitely a surgical indication for the adult patient. But nowadays, with the test, we can try the combined intrusion and retraction force system for these gummy spine cases. But for the etiological factor of muscular factor, it means the short upper lip or hypermobile upper lip, the treatment effect may not be good enough. So, for this lady, actually I suggest her to receive orthodontic surgery, and she said yes. So very easily we can achieve this kind of improvement without too much effort after orthodontic surgery. And I would say this is the best. However, there are many patients, they do not want to go for surgery. So we just try the combined intrusion and retraction force system after 4-bar extraction and also wisdom teeth removal. I also always suggest the patient remove the wisdom teeth in this kind of patient, which we try total arch digitization, because we need the room for the dentition to retract. So with the force system on the top and the bottom, of course, you can close all the spaces, and here is the treatment comparison. For the gummy smile, it was totally corrected. But for the retreated chin, it looks much better because the relatively retraction of the lips. The symmetric superposition looks like this. There was some active vertical control, intruding the whole upper dentition and rotate the mandible a little bit. So you can see the chin projection was improved pretty much. I did a small study in my patient group. Over 10 years period, there was 159 cases complaining gummy smile, and the success rate of using the combined intrusion and retraction force system with tests, the success rate was up to 97.48%. So I would say it's pretty predictable. And who are the exception? The muscular factor. If they have hypermobile, there is no way you can correct the gum spine unless he can receive some Botox. And in addition to gum spine correction of these cases, we may notice the facial profile improvement was also very good because they are all adults. Most of them patients are adult patients. They do not have growth. So we call that mandibular response. And you can see very obvious mandibular response in these patients to improve their facial profile. Like this, not only retraction, but also vertical control. So case after case, we can see a lot of these kind of patients. However, there are always limitations, right? When this patient came to my office, I said, no, you are definitely a surgical case, right? So I turned her down. But she came again. She came again. And still asked for non-surgical treatment. So I said, no, there is no way I can treat this kind of case because I know it's not predictable. The improvement was limited. But she came the third times. So finally, we accept with the understanding that is camouflage treatment. The treatment result might be compromised. So with wisdom teeth removal, 4-bar extraction, we started to retract and intrude double arch. However, if you look at the progress, you may see here the anterior open body was noted, right? Anterior open body was noted. Yeah, anterior test, we can intrude the upper incisors very predictably. But for the terminal molar, the arch wire, not very strong. And the test cannot cover bilaterally. I mean, at the anterior side and posterior side of the molars. So I decided to add another buccal test distal to the terminal molar to focus on molar intrusion. But you know, Addis has put transpartal arch inside, but I did not have, so I decided to put another mini screw on the palatal side to focus on molar intrusion, trying to intrude the molar to solve the open bile. So gradually, 4 months later, we can see the open bile was reduced because the molar was successfully intruded. So the occlusion can be successfully settled like this. And here is the final treatment outcome. Occlusion-wise, almost look the same. So the point is about how does the patient satisfy with the profile and the gummy smile. Here, the gummy smile was corrected. So this one is quite severe, but still, without the muscular factor, we can correct the gummy smile. And the facial profile improvement, a little bit improvement, but not very good, right? I dare not say it's good, but the patient was satisfied. Before and after OPG, cephalometric superpositions, we can see a large amount of incisor intrusion, up to 6, because in the past I have never seen this amount of incisor intrusion. And molar intrusion to 4, because it's so obvious. Total arch intrusion, so that we can get this kind of counterclockwise rotation. And you may see here the bony exoastosis. Actually, they were there before treatment, just because all the other bone was following the incisors. But however, there would be some dense bone left behind. That's why we can see these kind of bony exoastosis. And the medial plane angle was reduced from 49 to 45. And also we can see the improvement of the chin projection before and after. So I did the case report in Dr. J. Park test book on the test. If you are interested in this case, the details, please refer to this article. If you need the article, just write it down, your email address, I will send it to you. But I'd like to show you this. Do you remember, usually, after 1.5 years, usually we close all the spaces, and the profile improvement was basically okay. But you can see 2 years. It's a long way. I do not know when I can be relieved. So it's a little bit stressful, right? That's why I reject the treatment initially. And here are the post-treatment follow-up. For this lady, I think she was very happy because she does not need to receive the orthodontic surgery. However, we can see, although basically combined intrusion and retraction forces looks good, but not so predictable, because sometimes individual variation, you need to look into every case, the progress of every case. And if there is something else, you need to figure out something to fix it. For this case, we need more molar intrusion, right? Because anterior part seems okay, but posterior part does not work. So here we see another case, a very similar case. I would say, again, that you should be a surgical case, not only the front gummy smile, but also the posterior gummy smile. It's terrifying, right? And I would say, okay, I would suggest you a surgical plan. But however, many patients does not want. And here we can see another missing of upper left 6. But it's okay because mesial drift, we just use the 7 and 8 as the 6 and 7. Besides that, 4-by extraction. After that, combine intrusion and retraction. However, in this case, I tried to use the mid-palatal test instead, trying to intrude the upper anterior because the bite is not really deep. So I start with the upper combined intrusion and retraction force. Set 11 months, we can see the progress. What do you see? The molar was intruded, but the upper incisor, although intruded a little bit, it derotated, but it dumped. The torque was lost. So you cannot see any mandible response, right? No forward rotation of mandible. And the facial profile improvement, not much. And we have closed most of the spaces, right? We have closed most of the spaces, but the facial profile was not satisfied. And the muscle tension was still there. So I think we may need to change some strategy. I need more total arch intrusion. And so I decided to bump the TBA on the first molar, upper first molar. And do you remember I used a mid-palatal screw? Then I insert a second one. Then I design an appliance like this. The solid line means before activation. So after I secure the appliance over the mid-palatal screw, then I activate the cantilever, hook on the circle, on the TPA. Are you with me? Activation from the high palatal vault to hook maybe like this. The cephalogram. Initially, before activation, it was on the high palatal vault, but I move it down to hook on the palatal arch, to hook it beneath the hook on the palatal arch, so that the TPA receive an intrusive force. Do you get it? So the upper molars will be intruded. Okay. Here we can see 3 months later, the TPA was impinged into the soft tissue, which means the upper molars were intruded. And at this time, can you see here the molar relationship? I cannot believe it. It's class 3. This is class 1 case. The anchorage in lower is stronger. But nowadays, she was class 3 molar relationship, which means counterclockwise rotation. just like Adi said, right? Counterclockwise rotation. What should I do? I need to control the low molars. So I use buccal shelf test. But I submerge the buccal shelf test with the wire extension to exert the intrusive force and also the retraction force, trying to correct the class 3 relationship, trying to correct the class 3 dental relationship, and also intrude the low molars so that I can get double arch active vertical control. Okay, so 5 months later, you may compare here and here. Now, the canine relationship was class 1 bilaterally. And here is the final treatment outcome. After complete space closure, in the mid-treatment, the facial profile was not good. The lip incompetency was still there. But with the active vertical control, we can intrude the upper and also we try to intrude the lower. So we can get the lip improvement and also relieve the muscle strain. And the gummy smile was totally gone. And the requirement for this successful gummy smile correction was not only anterior intrusion, right? Because she was both anterior and posterior gummy smile. And here is the before and after. So again, you can see not only anterior intrusion, but also posterior intrusion, so that we can get counterclockwise rotation of the mandible to relieve the muscle strain and improve the facial profile. The mandibular angle was also reduced significantly. And so, because this mid-treatment record, you can recognize this is only sagittal. But after that, with the vertical, you can achieve treatment effect like this. And also the gummy smile correction. It is not me who invented this kind of appliance. Dr. Benedict Wilmis, you can see he used a cantilever arm to intrude the elongated upper molar. And he calls it a mousetrap appliance. But I try not to use the image of the mouse. So I decided to call the appliance MTAD supported cantilever clip, just like a paper clip, because the activation, the way of the activation is the same. And the next is a transfer case. Maybe a little bit similar to a case Dr. Nut present in the morning. Do you see here? Her cheek complaint, protrusion. And the second complaint, anterior crossbite. She had her upper premolars extracted, upper first premolar extracted. And the doctor closed the spaces on the upper arch. But she still feel very protrusive. So she talked to her doctor and asked the doctor to keep retracting. So the doctor keep the retraction with the test here. With the test on the buccal and retract the upper dentition. Gradually, it became anterior crossbite. Like this, and you can see the torque was lost, severely lost, and the root was outside the alveolar bone. The root was totally outside the alveolar bone. So my treatment plan was lower lower second premolar extraction and regain the upper incisor torque. But just Dr. not present in the morning, remove the appliance and let the body do their job to restore the healthy. Then we start using TAS. Start bonding the braces and use the rumwa to align, then gradually go into the rectangular arch wire to regain the torque. Of course, after we can bend the arch wire, we start to put some plateau torque. Then, in the 9th month, we start to close the lower spaces. And at this time, you may notice the anterior core spine was corrected, the upper incisor torque was regained. The CBCT image showed that we can bring the root back to the alveolar bone. After that, although it looks we solved the problem, but still, her chief complaint about protrusion. In my point of view, we need to work on sagittal and also vertical. So I decided to close the lower spaces and use the mid-plateau TAS supported, I call it elastic hang rack appliance to ensure the upper posterior teeth. Because with these two mid-plateau TAS, we are able to apply the intrusive force everywhere you need it. If you feel this is a little bit complicated, just take a picture and send it to the lab. They will know how to fabricate. You see, I just use this part, mid-plateau TAS, as anchorage. Then the extension, just like, picture hang track around the room, right? Then if you want to put the paint over there, just hang it there. So it's quite, I think it's quite cost effective because you do not need to put too many knee screws. Of course, if you can put a less number of the knee screws as possible, of course it's good. Do you remember she came to me with the many TAS, right? And this one is the original one. And I think if there is a proximity between the TAS and the roots, there is no way for further improvement. If you like to visualize, no way. If you try to intrude, there will be some interference. So I try to use submerged ICC. It means move the TAS buccally and apically to submerge to avoid any possible interference between TAS and the moving roots. Do you get me? Then I just use the two plateau TAS to apply the force I like. And here is the end. We fix the occlusion and also we improve the facial profile like this. This is not about retraction. Yes, we need retraction, but it's about vertical. Do you get it? At least we need to have this concept. Then we can do what we need. If you look at the OBG here and here, you can see a lot of molar intrusion. But for this kind of molar intrusion, actually, of course, if there is a test, of course you can intrude. However, so distal, so terminal, it's not so easy to apply the intrusive force there. With the wire extension, of course, I can, you can, because we extend the arch wire there, and we have the test as the anchorage. And here is the symmetric superposition. So obvious counterclockwise rotation. So obvious active vertical control to intrude the whole upper arch. And the mandibular angle was reduced. Here is the pre-treatment when we close all the spaces, and here is the post-treatment after you add the vertical effect. And many doctors worries about the roots. Initially, it was outside the labial plate, but after I retracted maximally, it seems plateau to the plateau plate. And that is not good, right? Periodontal. But if we look at the CBCT, this is the same view. However, in this section, there was plateau plate. You can see here, there was plateau plate. From the axial view, this is before and this is after. Different level, CEJ level, 5 mm above, and the root apex, you can see they were within the alveolar bone. They were within the alveolar bone. So it is not, we retract too much. Even though we retract that much, still they are within the physiological limitations. So I wrote this up in AJODO Clinical Companion. Please refer to the article for the details. And I'd like to tell you another story about after so many different cases, we started trying to look into the effect. Where comes the treatment effect of the vertical? So we grouped 69 high-angle protrusion cases were allocated into 4 groups according to the test configuration in the lower arch. Because all these cases, we use the ICC test and the upper anterior test. But for the lower arch, the group 1, no test. The group 2, only lower anterior test. The group 3, only buccal shelf test. And group 4, both anterior, lower anterior, and low posterior test. And we look into the soft tissue retraction, the amount of soft tissue retraction. Because this is what we care and what the patient care, how much we can retract. And we find that the greatest amount of soft tissue retraction lies in this group with the upper and lower anterior. That means combined intrusion and retraction force system on both arches. If we look into the lower lip to E line, this group was up to 6 mm. Just give you an idea, we compare these similar study to evaluate the soft tissue retraction, lower lip to E line. When we put these numbers together, we can see lower lip to E line with test 4.8, around 4.8, very similar to this one. if I only have low posterior test. But when we have the anterior test, the amount of soft tissue retraction was up to 6. If we compare the setup of our cases and the other 2 studies, the difference may lie in only anterior test. I mean, the angle setup, only the anterior tests are different, because every study have upper posterior test and also have lower posterior test. But ours, we got to have anterior test. And when we look into the numbers, we can see the vertical effect got very prominent when this group got the anterior test. It's very straightforward. Actually, that is very straightforward. That means if you have posterior test, you can have more retraction. But if you have anterior test, you can have more vertical effect. Which means if we can have the posterior test and anterior test at the same time, we will have sagittal and also vertical effect at the same time. That's why we got the greatest amount of profile reduction. It's not that we can retract more. We cannot retract more. It's just because we move the reference line forward. What's the reference line? The E line. The E line was moved forward. Why? The chin point. Because counterclockwise rotation moved the chin point a little bit forward. So we move the reference line forward by active vertical control. And I believe this is what Dr. Ardis told us in the previous session. So I'd like to show you another trial on active vertical control. Because in this case, actually, I did not feel that she is very severe. However, she was really very severe. Because not much crowding or something else, just complaint about the protrusion. However, you may look into the soft tissue thickness, pretty thick. So her response might be not very good. And OPG showed that a missing upper right canine. So the treatment plan was upper right deciduous canine, then upper left first premolar, then lower second premolar because endodontic involvement. So after that, how do we treat? Combined intrusion and retraction on the upper arch. And for the lower arch, I only use the lower test. Then I close all the spaces as regular. However, it seems smooth. However, the facial profile look awful, right? Not very good. What can we do? She also complained the gummy smile. I tried to use a mid-palatal screw for further retraction of the total maxillary arch. As we can see, the canine relationship was still class 2. So one more mid-palatal test. However, look at here, the overjet. Not enough overjet. We need to retract the lower dentition using the buccal shape test, so that I can retract the upper arch more, right? But at this kind of time, I mean, when you try to digitalize the whole arch, actually we need to look into the CBCT to check any possible interference. If there is interference, this will not work. So we need to see if there is contact between the test and the roots. And here we put a new mini screw here, a little bit upward and a little bit buckle, so that I need to extend a wire to intrude and retract the whole dentition. After complete space closure, there is no spaces anymore. I need to digitalize the whole upper arch. And again, I try to use the submerged IZC test for intrusion and retraction of the upper arch. And palatally, I add the elastic hang rack to apply the intrusive force. Besides that, for the lower arch, I try to use the buccal shaft test to provide the intrusive force for the active vertical control over the lower dentition. However, you must know when we try to intrude the low molars using the buccal shaft test, there is a tendency of buccal rolling of the low molars, which we do not want. So we need to bond lower lingual arch to hold the front to prevent the buccal rolling of the low molars during the low molar intrusion. So I think that is total arch intrusion setup for both arches. So 2 months later, do you notice the occlusion settled a little bit? What does that mean? Active vertical control. No matter where the interference is, I just intrude it to disocclude so that they can occlude together to correct the bite. And here is the before and after. You can see the facial profile was significantly improved after active vertical control. OBG before and after, before and after. And here, the active vertical control of the upper dentition. For the lower, still, I will feel it's quite difficult to intrude. But still, we need to make effort for the lower vertical control. The mandibular response was good, and the mandible, the mandibular angle was reduced. For this case, the periodontal surgery was performed after orthodontic treatment, and from the CBCT, I can notice that it was retracted pretty much to the palatal side. But when we look at the CBCT image, the reason we look at it like behind the palatal plate is because the bone, the palatal plate was scalloping. It was scalloping. So this is what I try to show you. They still have the palatal plate. The palatal plate was still there. So this is what I suggest for active vertical control on both arches. However, I would say it's quite challenging and very stressful. So I would suggest not to accept too many challenging cases in your daily practice. Keep it below, I would say 5%. Keep it below 5%, not too many. Otherwise, you will feel too stressed. Okay. And besides the sagittal and the vertical, I will say this kind of asymmetry case, I will try marking to coordinate between both arches. Otherwise, there is no way for this case to accrue. So for this gentleman, I use the marquee to expand, then start the fixed appliance as usual. Then we can close all the spaces with the IZC test for maximal retraction. And here is the final treatment outcome. For this gentleman, I would say if I did not expand the upper arch skeletally, there is no possibility for him to improve the facial asymmetry. Although not perfect, symmetrical, but it improved pretty much. And with the absolute anchorage, it can improve his facial profile pretty good. So this is the transfers. I think it's pretty important to consider these three dimensions at the same time. And I'd like to show you some other aspects of the asymmetry. For this lady, very obvious facial asymmetry. So I would say she must be a good surgical case. But since she did not want to go for surgery, so we just like to try non-surgical. But you can see her upper anteriors the condition are not so good. So we just decided to remove the upper lateral incisors instead. So upper lateral incisor and the lower right first premolar and the lower left first molar. For this lady, for this kind of substitution, of course we can do some composite buildup for temporary aesthetics. And then we start the retraction, the space closure of the canine to canine to substitute the lateral incisors. At this time, if there is any elongated molars, we use the palatal test from buccal side and palatal side to ensure it at the same time. After that, we just close all the spaces. But because of the wisdom teeth were impacted, we need to take care of the wisdom teeth after we close all the spaces. Because after you close the spaces, there might be some possibility for the wisdom teeth to de-impact, at least a little bit better. So after that, during the mid-treatment, the occlusion seems good, but during the management of the impacted wisdom tooth, there might be temporary open bind. And after that, we need to settle the occlusion again. So because of the dental midline, and the right side cluster, of course, we will use the midline and the right side cluster. The instinct of the orthodontist, everyone knows. So you can see the occlusion fit. But of course, that is because the occlusal plane was canted by us. Because this is a camouflage treatment. And here is the final treatment outcome. Debonding, the occlusion, I cannot say very good, but you see, for her,